Okay. Good evening, all. Welcome you all for the IPNA Endorsed Webmaster Series 2025. It is a pediatric nephrology symposium, and we are going to have talks only on chronic kidney disease in children. And it is spanning from April 9th to May 3rd, and every Wednesday and Saturday. And this is a webinar 3, and we have the polling session open for our pediatric trainees. And so the highlights of the webinar is all practical aspects of pediatric CKD will be delivered, and polling session for the trainees with a cash reward will be offered. And we also have the credit hours for the same. So today we have Dr. Jalpa, who's going to be our moderator. She's a consultant pediatric nephrologist at Tender Kidney Care. And she is also affiliated to many other hospitals, and she is also taking care of the major pediatric ICU hospitals in her place. And her specific academic interest is towards critical care nephrology, glomerular disease, and management of caput. She has got numerous awards to add on to her CV. And she has presented work at various international and national conference. And she has got publications in national and international journals. Over to Dr. Jalpa to introduce the speaker.
Thank you so much. Thank you, ma'am. First of all, at the onset, I would like to say thanks to you, to IPNA team and Dr. Amrish for giving me opportunity to be part of this excellent session. And, I would like to congratulate you that for last 5 years, we are running this program. It's indeed a mammoth task to coordinate with all the speakers and, be there for twice a week almost. So congratulations to the team. So without much delay, I would like to invite our first speaker, Dr. Bobbity Deepthi. She's Associate Professor, Department of Pediatrics at JIPMER, Pondicherry. And her areas of interest are glomerular disorders, chronic kidney disease, and nutrition in CKD. She has various almost 60 publications in PubMed Index journals with almost 12 ongoing projects in pediatric nephrology. And she is currently the member of editorial board for ISPN Bulletin and scientific in charge for women in nephrology at Tamil Nadu and Pondicherry chapter. So I would like to invite you for her talk, which will be on nutrition in children with chronic kidney disease and can we make them thrive. So over to you, Dr.
Thank you, Dr. Jalpa, for that lovely introduction, and thank you, Dr. Kalaivani ma'am, for this opportunity. I'll just share my slides. I hope my slides are visible, ma'am.
Yes.
Yes. So today's topic, which has been assigned to me, is nutrition in chronic kidney disease and can we make them thrive? Well, coming to the introduction and background regarding why nutrition is so essential for chronic kidney disease, we need to understand that the chronic kidney disease, especially in the infantile phase, is predominantly nutrition dependent. The growth in the infantile phase is predominantly nutrition dependent, and hence it is essential. Also, there is enough literature to suggest that there can be long-term consequences when the nutrition goes wrong. In terms of high fat mass, low lean body mass, there can be increased central adiposity. And also, we know that the short stature and underweight ultimately lead to lower likelihood of a child receiving kidney transplant. And the adverse effects of this poor growth continues even after the kidney transplant. The mortality rates are higher in children who are in the extremes of the BMI, either underweight or obese, and or extremes of the height for age, like short stature. Also, the nutritional adequacy has been related to improved cognitive outcomes as evidenced by all this literature. And another important aspect is that the period of vulnerability is extended in the chronic kidney disease. When we say that infantile phase is most important, that is 1 year, that applies for normal children. However, in chronic kidney disease, the growth phase extends for extra 2 to 3 years, and the initial 2 to 3 years are a period of vulnerability and the nutrition has to be taken care of. There are a number of other studies which also say that nutrition is a predictor of the kidney outcomes. Like one of these recent studies in 2023, where almost a huge data set of 11,873 patients were studied, aged 0 to 19 years. All these children had undergone KRT, kidney replacement therapy, from 1995 to 2019. And they found that children who were short stature or those who had extremes in BMI were associated with poor outcomes, and which again indicates that nutrition and growth is related to kidney outcomes. There's also evidence which says that for every 1 standard deviation decrease, there is an increased 14% risk of mortality. Also, when the height is below 3 standard deviations, there is higher risk of mortality. For every 5% reduction of weight over 3 months or 10% reduction of weight over 6 months, the mortality goes up. The BMI is also related to mortality. The serum albumin, with every decrease of 1 gram per deciliter, there has been found a 54% higher risk of mortality. And also the protein catabolic rate, the normalized protein catabolic rate, less than 1 gram per kg predicts weight loss in the adolescents, especially on the hemodialysis. So there's enough evidence to say that nutrition plays an important role in the kidney outcomes, mortality, and morbidity. Now, how do we address the terminologies related to this nutritional disorders? A number of terminologies are used, and the prevalence of nutritional abnormalities in CKD is very wide, ranging from 6 to 65%. The most extreme form is called cachexia. There can also be something called protein energy wasting, which we will be discussing in further detail. There's obesity, there's growth retardation. And previously, the nutritional disorders in CKD were addressed with number of variables. They were called uremic malnutrition, some called it uremic failure to thrive, protein energy malnutrition, malnutrition inflammation complex. But the most common terminology which has now emerged is protein energy wasting, which we will understand further. So what is this protein energy wasting? Protein energy wasting is nothing but a specific term for the metabolic and nutritional derangements occurring in CKD. So I highlight these things. It is both nutritional as well as the metabolic parameters which are involved here. It was first defined in the year 2007 by Varadi et al. And it was proposed and defined by the International Society of Renal Nutrition and Metabolism as a state of decreased body source of protein and energy. So it is a complex of both nutrition and metabolism. And how is it different from the protein energy malnutrition that we normally hear in the normal children? While PEW has maladaptive responses. What do we mean by that? That although there is so much malnutrition, the children continue to have reduced appetite, they have an increased metabolic rate, they have decreased protein mass, and fat may not be reduced. And it cannot be reversed only by nutrition, because as I've been telling again and again, it is a mixture of both nutrition as well as metabolic abnormalities. Malnutrition on the other side, or the PEM, which we use for normal children, there are intact adaptive responses. These children can still have hunger. They usually have reduced energy expenditure. The fat is reduced here, and the lean body mass is somehow preserved. However, in PW, which is specific for CKD, the lean body mass is most commonly affected. The pathophysiology of PW again is multifactorial. As this picture demonstrates, there are a number of things which contribute to this protein energy wasting in CKD. There are dietary restrictions. The children don't have the appetite or the taste or smell to take it. The fluid overload. There's increased inflammatory cytokines. There is coexisting metabolic acidosis, anemia. The number of cardiovascular abnormalities. There are dialysis-related inflammation, physical inactivity, and number of the uremic toxins, the hypercatabolic state, which ultimately leads to protein energy wasting. And all this is again further predisposes to infections, cardiovascular disease, and increased mortality and morbidity. So what is the global burden of protein energy wasting? So there is this nice meta-analysis which was published in 2018. And as we can see here, so the crude PEW prevalence was more than 80% in areas which are shaded very dark, and then followed by dark orange and so on. This was based on 90 studies on maintenance dialysis patients, 2 studies of transplant patients, and 5 studies of CKD 3 to 5 patients. But what is very interesting to note here, that not even a single study on pediatrics was present reporting the protein energy wasting till the year 2014. But why so? Because till 2014, there was no accepted definition for defining the protein energy wasting in children. The definition which was laid out in 2007 was predominantly used for adults. It was only in the year 2014 that Abraham et al. Came up with this classification or the criteria. What they did is they had 5 criteria: a biochemical criteria, a reduced body mass, there was a decreased appetite, reduced muscle mass, and poor growth criteria. So, and based on these 5 criteria, they again said that there's something called minimum PW. So if 2 of these criteria were satisfied, it would be called minimum PW. Standard criteria said that at least 3 of it had to be satisfied, and modified PW had 1 extra criteria, that is poor growth. So 1 to 4 was present for minimum PW and standard PW. That is 2 out of 4 would be called minimal, 3 out of this 4 would be called standard. And if you include 1 extra criteria, that is poor growth, which is specific for children, we would call it as modified PW. So how was this? So as you can see, even in this definition, there are anthropometric parameters related to BMI, there's height, and there is mid-arm circumference, and there is decreased appetite, and also the biochemical parameters. So how was this criteria different from the adult criteria? One thing is that they had added the biochemical parameters of low transferrin and CRP more than 3. And the subjective reporting of appetite had replaced the decreased protein intake criteria, which was present in adults. And 1 extra criteria was added, which is poor growth or the short stature, because growth is very specific and inherent to childhood, and it could not have been removed from the criteria. So there are a very limited number of studies on PW. One was in 2012-14 by Abraham et al. In the CKD cohort, and they reported a prevalence of 15%. And then there's a study by Iyengar et al. From St. John's, which reports 34%. And our recent study from JIPMER also has shown a PW prevalence of 26.7%. So it is safe to say that this problem of nutrition is very prevalent in our children, and more so in the ESKD. Now, knowing that there's so much prevalence, what do we do to identify these children? How do we go about giving appropriate nutrition to the children? For this, we need to understand something called nutrition care process. What is nutrition care process? It is a systemic way of dealing with a child who is having nutritional problem. So as soon as a child is referred to us, the first thing we do is do the assessment. We can do it by taking the history, identify the risk factors, use some tools for history taking, do the nutrition-focused physical findings, get the anthropometric measurements and biochemical data, proceed and identify the problem or get the diagnosis right, and then intervention, that is, we will make the diet prescriptions for these children, define certain goals, and finally monitor using indicators whether your intervention has succeeded or not. So this is the nutrition care process: assess, diagnose, intervene, and monitor and evaluation. So we'll go with each of these steps. Now, how do we do? Step 1, we want to do the nutritional assessment in children. So what can I do for the history taking? In the history taking, for some parameters which we need to understand is, what is the thirst of the child? Is there any polydipsia? Are there any, is there any increased urine output? Is there any constipation? How is the smell and taste? What age did the CKD start? What are the medications he is on? And how long has the child been on dialysis, or what are the fluid requirements? What is the existing proteinuria, comorbidities, etc. Along with this history, one of the most important histories in nutritional assessment would be the diet assessment. So dietary assessment, most of our residents are aware of this first method which is used for collecting the diet history, that is called the 24-hour diet recall method. 24-hour diet recall method, as we can see in this figure on my right. So we would write down the meal timings, we would write down what he's taking, in what quantity, like in cup or katori spoons. We would write down what is the quantity ingredients in it, and then we will calculate the 24-hour recall method. This is usually done for 3 days to get a better idea and also include the weekends. But then sometimes there may be a recall bias in this method, and it is little laborious. There's one more method which is used called sample food frequency questionnaire. So as it is seen in this image, it is more applicable for the community level, where you just want to know for a very large number of children, like, are you consuming milk? Are you consuming pulses? Are you consuming egg? And how many times do you consume? So if you have a very large sample size, then sample food frequency would be a good method. And then you have the food diary. This is the most convenient for it, especially for parents who are well educated, and they can be asked to write down and jot down whatever the child is taking over a time, at least for 3 days to 1 week. And when they come back, we get all the history. The fourth method is technology-based. Number of apps are available like DietCal and many other apps where we can real time, we can enter whatever they are taking and then we get all our values. So that is one way of taking history. So the first step is getting your history and getting your diet history. Then we proceed with the nutrition-focused physical examination. When we say nutrition-focused physical examination, we are looking at the signs of malnutrition. Like, is there any muscle loss? Is there any fat loss, like in buttocks, saggy buttocks, or how are the cheeks? Are they hollow? Is there hollowness under the eye cheeks? Then whether there is any nutritional edema. We can also look specifically for the signs of micronutrient deficiencies in the skin, nails, hair, and eyes. So we need to basically elicit the signs of both subcutaneous fat loss as well as elicit the signs of muscle wasting. This is called nutrition-focused physical examination. Once we have done that, we move to a more subjective way or objective way of assessing the anthropometry. This is something which all of our residents are familiar with, but just brushing through the basics again. So you need to get your weight, and in CKD, most important is your dry weight or your euvolemic weight, because there can be children who are oliguric, anuric, they are on dialysis, they have some fluid overload or primarily a nephrotic syndrome. So it is important to get the dry weight because only taking the measured weight will give wrong calculations. Then length is measured for less than 2 years and height for more than 2 years. Head circumference is measured, weight for length for less than 2 years, and get your BMI for more than 2 years. But only the absolute values are not important. It is important to get the trends in this growth parameters to get an idea about what is happening to the child. So the PRNT guidelines recommend that we use the WHO charts. More than 2 years, we can also use the country-specific charts, but most important is to plot the trends. What is happening to the height? Is it increasing? Is it going in the same centile, or is the centile dropping? The Kadilkar et al. Have also laid down the height velocity charts, which can also be used for plotting the height velocities. So once we get our anthropometry, we plot them on our growth charts. We can use country-specific growth charts or genetic or disorder-specific growth charts. And finally, most important is to get this height or length velocity over a minimum of 6 months. Minimum 6 months is needed to get an idea. And you can further evaluate it by looking at mid-parental height and adjust it for premature infants, etc. Once you get it, what do you expect? So there are charts which have been given by PRNT to look at what is the expected weight gain. So you can compare against it and first of all, determine whether your child is having some nutritional problem or not. After anthropometry, we can proceed with the biochemical assessment. While number of things have been listed in biochemical assessment, the most accepted ones are only these two things: the normalized protein catabolic rate, which is usually done on a regular basis in adolescent patients on hemodialysis. More than one is indicative of adequate protein intake, and another one is the serum albumin, which is considered to be good, but provided we have ruled out all other non-nutritional causes of hypoalbuminemia. There are some more add-on tools. We'll not go into the details of it, like blood urea nitrogen and creatinine, inflammatory markers, etc. So what is step 2? So now that you have taken your detailed diet history, you have got your anthropometry, and you got some biochemical parameters. Now you need to estimate what is the energy and protein requirement for your child. First of all, you determine whether the child is having protein energy wasting. Once that is done, we need to make a prescription for energy intake and protein intake. So before doing that, first determine whether the child is having normal growth. Is he having suboptimal growth because you have charted it on your WHO charts? Is he overweight or obese? So based on that, you're going to decide. In protein, what you need to do is you see whether you want an optimal growth. Do you feel the child is having persistently high urea levels, or is your child on dialysis? Once you have done that, there's something called suggested dietary intake, which has been again given by the Pediatric Renal Nutrition Task Force. In all other things, it is given as RDI. So from all the international publications, what the PRNT group has done is they have taken the average values from all the publications, and they have themselves listed a SDI, or the suggested dietary intake value, for energy, for protein, and similarly for fiber, calcium, phosphorus. So these all this data is easily available, freely available, accessible from the PRNT website. So you can use this and see according to their age, what is their suggested dietary intake. So using these tables, what should I do? What should my initial prescription be? The initial prescription or the most of the graded evidence says that you can start with the same energy calculation as for a healthy child of same age group. So maybe 100 to 110% of the whatever you would have given to a normal child. For optimum growth, if you feel that child is having suboptimum growth, then try to use the energy intake towards the higher end of your suggested dietary intake from the tables that I showed. So there was some end. So like suppose 2 years, it is 81 to 95. If you feel the child is having suboptimal growth, use this 95 kilocalories per kg per day. If it is optimum, maybe you can use around 85 kilocalories kg per day and so on. Use and when it comes to protein intake, again, target the protein intake at the upper end of the SDI for optimal growth. However, in situations where you feel that there is persistently high urea levels, you can use the lower end of the SDI after making sure that there's no other cause for high urea, like say you have given steroids or maybe the child is dehydrated, etc. Ensure that the adequate energy intake is going on, but never reduce the protein intake below the lower end of the SDI. And the protein intake should also be increased to a certain extent in patients who are on dialysis. There's more protein losses in children who are on PD, so they would require around at least 0.15 to 0.3 gram per kg per day for PD children and 0.1 gram per kg per day for children on HD. Coming to the step 4, so we have dealt with the energy with the protein. Now we want to know how much fluid should I give to my child who is CKD. So again, that would depend on your volume assessment. Does this child need a restricted volume because he's having oliguria or he has become completely anuric, or he's having normal urine output, so you want to give normal volume? Or is there a tubular condition where he's still having polyuria and you would like to give additional volume? So first we need to determine what volume condition your child is in. Based on that, if it is an infant, then the guidelines say that you should continue giving breastfeeding or express breast milk. If that is not available, then whey dominant infant formulas are preferred over the casein dominant infant formulas because they have low renal solute load. If you feel that you need to give restricted volume, then you can go on concentrating this infant formula. A standard infant formula is concentrated to up to 13%, but you can go on increasing this concentration by 1 to 3% till you reach 20%. But while doing this, we need to be careful that every increase in the concentration of the formula is going to increase the osmolality and hence lead to some side effects like diarrhea, and your solute load might increase. The potassium might go up, phosphate might go up. There's a good chance the child might have vitamin A toxicity. So in that case, if you feel that the child is also having high potassium and phosphate, and so you're not able to concentrate the infant formula, that is when you can fortify these formulas. Instead of concentrating them, add more energy dense feeds, but don't add too much protein or phosphate. Protein and phosphorus usually go together in most of these cases. So you can just add energy dense feeds, which are high in calories, but not very high in proteins. You can add glucose polymers or fat emulsions. There are a number of commercial nutrient dense liquid formulas also which are available. In a child, the principles would remain the same. Now coming to the food part. So that was about the fluid part. Now what will you do about the food? For food, the management guidelines are almost similar as you would do for any healthy child, that introduce solids, considering the individual needs, introduce food which are varied flavors, textures, context. Always aim for a healthy, balanced diet with a variety of food choices, and account for the dietary limitations. So based on what is the potassium and phosphate level and sodium level, based on that, you're going to advise dietary limitations and not just a blanket statement that I need to restrict potassium for everybody, restrict phosphorus for everybody, or sodium for everybody. That would always have to be individualized. So as I said, if you want to increase the energy content, you can add foods which are high energy foods like refined carbohydrates or pastries and cakes. But then we have to remember that these are very low protein foods. If you want high protein foods, that is, you want to ensure optimal growth and you're targeting a upper end of the SDI of protein, then you can introduce a lot of dairy, egg, meats, fish, nuts, legumes, and lentils. You can fortify the foods they are taking in drinks. You can add additional nutritional supplements. You can add vegetable margarines or oils to the savory fruits. Sugars can be added for increasing the calories and so on. So having said this, an ideal situation where we would think that we will add all this, and if the child accepts everything, it is well and good, the weight will increase. But then we have to understand that there are a lot of barriers in CKD to adequate oral intake. One of the major causes is gastroesophageal reflux, but it is more common in infants. There was a study which was studying the practices which are prevalent in CKD with respect to food intake, and they found that 59% of them often refused food. 52% of them vomited excessively, 71% had to be force-fed. And another thing is they lose their smell and taste function, and they're not very eager to eat. And also, the HD and the PD are automatically a pro-inflammatory state, and the leptin levels are increased in them, which inhibits the hunger. So there are a number of barriers to adequate oral intake. Our job doesn't end with saying that, okay, feed your child well, give this calories, give this proteins. So when such barriers exist, what should we do? So we can provide nutritional support in the form of enteric feeding. So what is enteric feeding? The most common is either nasogastric feeding or gastrostomy. Nasogastric feeding is the normal your NG tube, which can be put, but it is for short term. It requires frequent replacement. Obviously, it gets displaced very frequently, and it has nasophageal irritation. And because it keeps the sphincter open always, so there is chances of gastroesophageal reflux also worsens. Gastrostomy is a good option for long-term enteral feeding, and it can be done in small children. I know a lot of us don't do this, and we are very hesitant to do the gastrostomies, but it is a wonderful way of getting the nutrition in. So it is a safe and effective procedure, usually done under GA. So as you can see in this figure, usually a small gastrostomy tube is put into the stomach, and the stomach lining is stitched to the skin. And you can use this tube for giving the food and delivering the adequate calories, proteins, etc. till the child starts gaining weight or till your targets are met. And if you're doing it in the setting of CAPD, it is always preferable to be inserted before or at least along with the PD. There definitely are certain complications, theoretical complications, like there can be leaks, there can be esophageal hernias, but most of the studies have shown that even parents have started liking gastrostomy because they can see that child is gaining weight. And in fact, after getting used to gastrostomy, it is a challenge to bring them back to the oral feeding. But yes, gastrostomy or the percutaneous endoscopic gastrostomy tube is a very good option in long-term nutrition management. Coming to the fifth step about estimating the dietary calcium and phosphorus intake. So dietary calcium and phosphorus intake is, again, you get it from your 24-hour recall method. Most important is identify what are the dietary sources of calcium like milk, etc. Recognize the processed foods which are containing the phosphorus additives and estimate how much amount is going. The SDI or the suggested dietary intakes are again available from PRNT. So once you have got it, our aim is to maintain calcium levels and phosphorus levels within the normal range. So calcium of 9 to 11 we want, and a phosphorus also we want to maintain in 2 to 4, maybe for older children, and 4 to 6 in younger children. So based on that, identify whether this calcium is coming from diet in the form of medications like your phosphate binders and dialysate fluid. So look at all the sources and try to adjust the calcium levels. Calcium intake should be or within the 2 STI. If there is persistent hypocalcemia, sometimes you can shoot up and go at very high levels, but usually there's no need to exceed twice the STI. Dietary phosphate intake, the main source is the phosphorus additives which are present in this processed foods. So although we say that your whole grains, pulses, etc. also have high amount of protein and phosphorus, but the processed foods have a lot more of phosphorus, and they need to be adjusted, and don't cut down on the healthy foods like your whole pulses or grains or fruits or anything for that matter. These are some sources which I have listed here. A more detailed list is present in the PRNT guidelines. Finally, coming to the potassium. Potassium, again, it is a myth that potassium has to be restricted in everybody. No, potassium need not be restricted in every CKD case. You have to look at the potassium levels and decide whether you have to keep the potassium levels between 3 to 5. So depending on whether your child is hyperkalemic or hypokalemic, you would go ahead. Suppose the child is persistently hyperkalemic, then identify all the of course, dietary you have to identify, but before that, just see whether there are any medications containing potassium, like RAS inhibitors. Is the child on something like CNI? Has he been started on antibiotic for some reason? Identify some non-dietary causes like constipation, low GFR. See whether he's on a lot of processed foods with these additives. So cut down on those and then only come down on the dietary intake of potassium. That again, try to do it in the processed foods rather than cutting down the fruits. Hypokalemia, identify whether there are any GI losses. Is it predominantly a renal tubular disorder? Are there any loop diuretics going on, or have we implemented a too rigid restricted potassium diet? And get those factors into control and maintain your potassium levels. So there's a lot of information freely available. The Indian Renal Food Guide, all the recipes of both North Indian diets, South Indian and Central Indian diets are available from the Indian version of the PRNT, and they can be used for getting your potassium levels. Finally, this was all about oral intake and enteral tube feeding and all. But what if the child continues to have poor growth? And I have already tried my gastrostomy. I have given adequate calories. I have given adequate protein. Nothing seems to be working. It is in such situations that there's something called intradialytic nutrition can be tried. We know that hemodialysis is usually inherently pro-inflammatory and catabolic and results in loss of amino acids and hence the poor growth. So the idea is that during the hemodialysis in the venous chamber, if you are able to get in some amino acids and the diet, the intradialytic parenteral nutrition, it says it is set to improve the dietary intake. It increases the albumin and pre-albumin levels, increases the lean body mass, and it has better patient adherence and satisfaction. And also the food which you're giving during the HD also helps in counteracting this pro-inflammatory cytokines which are increased. But yes, there is a small risk of hypotension and reduced KT/V aspiration during this. But by default, meals during HD has been considered to be a standard of care. And there's a beautiful review which gives us a roadmap for how to use this. Although there's limited data in children, but this particular roadmap and this particular review article tells us that once we have failed on oral and tube feeding, we can give this in intradialytic parenteral nutrition through the venous chamber. It bypasses poor compliance. We can give dextrose, amino acids with or without lipids. Sorry. And we can provide up to almost 500 to 1000 calories. I'll not go into the details of it. I've referenced this article, so we can go through it. And what is most important here is that there are some ready-to-use IDPN solutions which are present, and it should always be a graded approach. Start with very slow amounts and go on increasing till you attain your targets. And finally, most important, after you have implemented everything, we did our nutritional assessment, we diagnosed what was wrong, whether energy was low, protein was low, calcium, potassium, etc. We have intervened by making these dietary interventions using all the PRNT guidelines and all the material that they have given us. The final step is always to monitor and review. Make sure that the child is having consistent weight gain and increased height velocity, and whatever you were trying to identify wanted for the child, and identify if any other barriers are still existing, and again go back into the same loop, again assess, again diagnose and intervene. While I kept on emphasizing that nutrition plays an important part in enabling optimal growth by optimizing energy, protein, phosphate, etc. But we also need to be aware that protein energy wasting is not a result just of the nutrition, but also of number of metabolic parameters. So simultaneously, correction of acidosis, correction of bony deformities and MBD, and growth hormone replacement only if required, and early preemptive renal transplant or growth-friendly immunosuppression also have to be taken care of. So the key messages would be that growth impairment definitely is severe in CKD. It is more pronounced in smaller children or the infants, and in advanced stages of chronic kidney disease. One needs to understand that protein energy wasting in CKD is complex and is multifactorial, and it is different than malnutrition in the sense that it involves both nutritional aspect as well as the metabolic derangements which are inherent to CKD. The growth parameters do predict poor outcome and the effects stay after kidney transplant. Hence, nutrition has to be taken care of. Nutrition plays a huge role, especially in infants and young children. We are always worried about the long list of medications that we give to our children, but it is high time we identify that nutrition has to be also given equal importance. Previously, we didn't have enough guidelines, but now there is enough guidelines to do this everything in a systematic way. And the suggested dietary intake values are also available for almost everything. Based on that, we need to get the adequate calorie intake, optimal protein intake, low phosphate and potassium only if necessary to improve the growth. Gastrostomy, though most of us are hesitant, it is a very good long-term option for nutritional support and should be tried in children. Additional protein is needed in children who are on dialysis, especially those on PD more than HD because of the increased protein losses. And finally, the intradialytic parenteral nutrition should be considered if PEW persists despite our oral and enteral feeding efforts that we have taken. Thank you.
Excellent talk. Very well explained nutrition in chronic kidney disease in the most simple yet comprehensive way, Dr. Deepthi. And as you have rightly emphasized that in pediatric chronic kidney disease, it is not only PEM, that is protein energy malnutrition, it is also the protein energy wasting, which we all need to consider. Participants can ask their questions in the question answer box, and I think we can take questions at the end with after completion of our second talk. Okay. So I guess we can proceed with our second session. And for that, I would like to invite our next speaker, none other than Dr. Kalaivani Ganesan, ma'am. And she's head and senior consultant pediatric nephrologist at Mehta Children Hospital, Chennai. She is mentor for IPNA Junior Empowerment and Mentorship Program 2025. She is course director for our IPNA Fellowship Program, and amongst various awards she has received, few of them are FISN Awards for 2023, Award for WKD Project 2022, and she has been the recipient of ISN Grant for 2018-2019 to 2022 year. And she has remained secretive committee member of Nephrology Association of Tamil Nadu and Pondicherry in past. And she is reviewer of many pediatric nephrology journals. And her areas of interest especially are critical care nephrology, glomerular disorders, and chronic kidney disease. Her topic today would be immunization in children with chronic kidney disease. Over to you, ma'am.
Thank you, Jalpa, for the kind introduction. Like, are my slides visible?
Yes. Yes, ma'am, they are visible.
The slides are moving?
Not yet, ma'am. I guess you need to do that slideshow. Still, the slideshow has not been started.
Okay. Is it now?
Not yet. Still, it is in the other way. Yeah, it's not moving yet. We are not able to see the slides yet.
One second, one second. Is it visible now? No.
No, not yet. Yes, the screen is visible.
Now?
Yeah, the slides are visible, ma'am. Yes, it started. Slideshow has been started. Yes.
So is it moving now?
Yeah, it is moving perfectly. It's right.
Fine.
Yeah.
So sorry for the delay. So like my topic would be on immunization in children with chronic kidney disease. So for the next 30 minutes, we'll be covering on a short introduction on vaccinology. What is the reason behind children's getting vaccinated, especially in children's with nephrotic syndrome and chronic kidney disease? A little bit about vaccine immunology. And we all understand that most of the pediatric CKD children's are basically the primary disease are either CACUT or they have glomerular disease. And in glomerular disease, they are exposed to a lot of immunosuppressive drugs like steroids, calcineurin inhibitors. So like we need to divide them for a clinical practice and practicality purpose, or as children who receive steroids and children who are on steroids along with other immunosuppressive medications, and children who are awaiting renal transplantation. And few words about immunogenicity and a little bit about the individual vaccines for CKD children's, and what are all the indications for travel vaccines for immunocompromised children's. So we know that per se the CKD children are exposed to a lot of immunosuppressive medications, and this pushes the children for lot of infections. So when you look at the vaccinology, like when a child gets a vaccine or a natural infection through immuno or through a microorganism, you have stimulation of both your T cell and B cell, and this stimulates your memory cells, and your memory cells plays a key role in the permanent effect of your vaccines. So what is the reason for immunization in nephrotic syndrome and CKD children's? So it is always a risk-benefit balance, and children may have quantitatively diminished immunological response or develop diseases caused by the vaccine pathogens. And all immunosuppressed individuals have a very low seroconversion rates. So it is always better that and when compared to the adult population, the seroconversion rate, though it is less in immunosuppressed children's, it is much better than the adult population. So this tells us that it is important to get all the vaccinations on time, and our primary goal has to be early completion of the recommended vaccination. So what are all the reasons for immunization in CKD? So as already discussed, it is a immunocompromised states. And what are all the risk factors which pushes these children to high infections are your presence of edema, your proteinuria where you can lose a lot of IgG, your uremia per se, it creates a poor immunomodulatory effect and catches up a lot of infection, your malnutrition in CKD children's, dialysis, and added to it, these children are exposed to high immunosuppression drugs. And even transplant per se, pre-transplant and post-transplant also, they receive a lot of immunosuppressive drugs. So when you look at the vaccine immunology in immunosuppressed children, like soon after a vaccine is given, they mount a antibody response within 2 to 4 weeks of administration. And the first antibody to raise is your IgM, followed by your IgG. So like in due course of time, the IgM antibodies quickly falls, whereas your IgG antibody stays for a longer time. So if you look at this graph, this is a response mounted when you have a natural exposure to any disease. So in this case, you have a longer stasis of your memory cells. But when it is a vaccine which creates your antibodies, the peak is quick, but it slowly wanes off in due course of time. So the natural memory cells are very high, and it stays for longer time than when you give a vaccine. So whenever and in immunosuppressed children's, your live vaccine and your conjugate vaccines are more effective. It is basically because it is stimulates the T cells, and it has a better antibody response, and it stays for a longer time. As said, like in the previous slides, I have said the IgM raises first, but it falls off quickly, whereas IgG raises slowly, but it stays in the serum for a longer time. So to sustain your IgG levels, which helps in your memory cells, there are you need to give adequate booster dose or booster dose of the same vaccine, or it happens when there is a natural contact. So for all practical purpose, we can divide children as children who are receiving steroids and along with steroids, other immunosuppressive drugs, and children with prospective or post-renal transplant status. So what is the role of steroids in immunosuppression? So steroids, we all know it is an immunosuppressive drug. It inhibits your CD4 cells, which is a helper cell, and thereby it lowers your antibody titers. And we all are very much aware that nephrotic syndrome per se, it is a dysfunction of your T and B lymphocytes. So the total serum IgG levels, which is lost in the urine during the course of proteinuria, and this is because due to loss of proteins, IgG levels are also lost, and this is the main reason why these children have a very poor vaccine response. So when do you call a child as a immunosuppressed child? When comes to steroids, any child who is on steroids of more than 2 milligram per kg, or child who is receiving more than 20 milligram daily, or alternate day dose for more than 14 days are considered to be immunosuppressed. And we also know that antibody levels in nephrotic syndrome may vary during relapse and remission, and it is better to cover all the vaccines during the period of remission to have a better response. So in a study done by Han et al., it has been noted that the vaccine, children who received the vaccine as a part of routine childhood vaccination had a better antibody titers than children who received the vaccine during the onset of nephrotic syndrome. Despite giving the doubling the dose, the antibody titers was less after the onset of nephrotic syndrome. So it is important to cover vaccines during the period of remission. So what are all the other immunosuppressive drugs which actually can interfere in your vaccination mechanism? So next drug is your cyclophosphamide. It basically inhibits the DNA replication, and children who have received cyclophosphamide, the live vaccine is contraindicated for the first 3 months. And next is your mycophenolate mofetil. Here, your mycophenolate mofetil basically acts on your inosine monophosphate dehydrogenase, which is involved in the purine synthesis. So this inhibits your T and B cell lymphocytes. So actually, children who have received mycophenolate, they have to stay away from live vaccines or contraindicated for the first 1 month. So for cyclophosphamide, live vaccines are contraindicated for 3 months, and for mycophenolate, it is contraindicated for 1 month. Next, going on to calcineurin inhibitors. So your tacrolimus, your cyclosporin, all these drugs are going to act on your FKBP protein, which acts on your calcineurin. So it basically inhibits your interleukin. So children who had received calcineurin inhibitors as a part of treatment, live vaccines are contraindicated for minimum of 1 month. And apart from your glomerular disease, there are a lot of vasculitis where children can be exposed to azathioprine, which is basically an anti-metabolic drug, and it causes inhibition of your lymphocytes. So when children are exposed to azathioprine, you should try avoiding live vaccines for a minimum of 3 months. So next is your sirolimus, and like sirolimus basically acts by in the G1 phase of your cell cycle, which then impairs your cytokine production and B cell function. So children who have received sirolimus, live vaccines are contraindicated for minimum 3 months. And the next is your rituximab, which causes depletion of your B cells. And these children, you should try avoiding live vaccines for minimum of 6 months. So like all that we have to understand regarding immunosuppressive drugs, or all the immunosuppressive drugs is going to interfere in the same pathway where your vaccines are going to act. So what are the barriers to optimal protection? So like few children's on renal replacement therapy or post-renal transplant, they produce a very low specific serum antibodies to whatever vaccine we have given. So to overcome that, what we have to do is you need to have a repeated vaccination with increasing dose. Say like for example, if the child, the normal hepatitis dose for the normal pediatric population, whereas in CKD or any immunocompromised state, you will have to double the dose of your hepatitis B. So increasing the dose can prevent, can mount a good antibody titers. Next is your vaccines. Vaccine serum antibodies in children with CKD have a tendency to wane. So in CKD children, usually the memory cells are very poor. So the immunogenic effect of the vaccines like fades off within 6 to 12 months. And this also tells us repeated measurement of your antibody titers and appropriate revaccination. Your booster doses are recommended in these children to overcome such problems. So what is your say on your vaccination after renal transplantation? So long-term graft survival has proven to be very important in pediatric recipients. So it is very much essential that all children after renal transplantation can also continue to receive your killed or component vaccines, and it is very safe after transplant, after renal transplant. And your live vaccines, as a general rule, it is not to be given for the first 3 to 6 months of post-renal transplant. It is because that is a time where you have a peak immunosuppressions to the children. So it is endorsed only when you have very specific indication where the benefits significantly outweighs the risk. So like healthy pediatric vaccines have a very good immune memory, whereas children with CKD, like I would like to re-emphasize that they have a very low seroconversion rate. So booster doses and doubling the dose will help in overcoming these barriers. So this is a checklist of immunization in a prospective renal transplant. So you should have a minimum dose prior to transplant. So the BCG has to be a minimum, at least one dose has to be received by the recipient. And in pertinent to your Tdap, it has to be minimum 6 doses, 4 weeks between the first 3 doses. And your OPV and IPV, usually like when you are planning for a closer renal transplant, then you try avoiding your OPV. The safer thing is to have a IPV. And your Hib vaccine, if the child is less than 2 years, 4 doses are recommended. If older than 2 years, it is going to be 1 dose. And your conjugate vaccine, that is your meningococcal conjugate vaccine, if the child is younger than 3 months, then 3 doses is recommended, 4 to 6 weeks apart. If older than younger than 1 year, then it is 2 doses. And if it is older than 1 year, it is 1 dose. So this is a summary of your immunization in a renal transplant, prospective renal transplant child. And MMR is mandatory to cover pre-transplant, as MMR cannot be given post-renal transplant. So it is mandatory to cover at least minimum 2 doses, 4 to 6 weeks apart. There is something called as even accelerated vaccination schedule. When your renal transplant date is very much closer, then you can have lot of accelerated schedules. So for example, instead of giving hepatitis vaccine on 0, 1 and 6 months, you can also keep it for 0, 1 and 2 months with doubling of the dose. And after the 3 doses is done, you will have to check for the antibody titers. In case if the antibody titers are low, then you will have to repeat the dose. So how do we, what is the recommendation of your immunization guidelines? So like we all know that CKD has got lot of major problems which can take a long way in your growth, nutrition, and a lot of social issues. And dialysis also pushes the child to a lot of trauma. So like parents actually overlook vaccination as a minor problem. So they just neglect vaccination, but vaccination is one thing which is actually going to prevent many of the problems. And there is also a misconception that lot of vaccines can per se create a disease status in a CKD child. So what are the 3 issues to be addressed in children with CKD? So like it is CKD on conservative treatment, on long-term dialysis, and post-renal transplant. So the risk of vaccine preventable disease has to be addressed. The safety and immunogenicity and clinical efficacy of available vaccine has to be addressed to the parents. And how do we implement for the child? So as said, it is immunocompromised state. It is basically because of the low seroconversion, because of the parallelly using of other immunosuppressive medications, low peak antibody titers even after vaccination, and more rapid decline of your antibody levels because of the poor memory cells, and loss of IgG in your urine or during the time of peritoneal dialysis. So what is the safety of the available vaccines for CKD children? So your killed vaccines and your component vaccines are very safe. There is no deleterious effects on renal function or prior or post transplant, no increased rate of graft rejection, and no effect on dialysis efficacy in patients on hemodialysis or peritoneal dialysis. All these things has to be addressed to parents. Only then they will come forward to get their children vaccinated. So other thing is like vaccination in children with CKD and transplant is safe, and there is no evidence that vaccination can cause reactivation of any underlying primary renal disease. And as feared by parents, it is not going to cause relapse of any disease. There is little percentage where after a meningococcal vaccine, you can have relapse of the primary nephrotic syndrome, but the percentage is very, very less. So what is the safety of your live vaccines in chronic kidney disease? So most of the guidelines do not recommend live vaccines, but a few studies have shown that live vaccines did not have any effect in transplant patients. So like though it is not a routine thing to be recommended, in a study done by Nauhaus et al., it has been reported no adverse effects after few adolescent transplant patients and was given MMR as a routine school vaccine. But it is not the routine recommendation. Live vaccines per se, it is not recommended post-renal transplant. So we'll move on to individual vaccines. So first is your BCG vaccine. So it should be avoided in patients who are immunocompromised. As already discussed, immunocompromised or when the child is on steroids more than 2 milligram per kg, if the weight is less than 10 kgs, or more than 20 milligram daily dose or alternate day for more than 14 days. Or like you can, once corticosteroids are discontinued, you can actually delay the vaccination by 4 weeks. It is completely contraindicated in post-kidney transplant patients. Moving on to hepatitis B. So like as said, they mount a very poor memory response. So you have to have a check on regular titers of antibody titers, and you have to repeat the doses if the antibody titer is less than 10. And doubling of the dose is mandatory in all CKD and dialysis patients, which will help to keep the memory cells. So annual testing of antibody titers is recommended in immunocompromised children. Moving on to MMR. So it should be avoided in children who are on immunosuppressive drugs, that as already discussed, steroids with this dose. And once steroids are stopped, you can actually delay the vaccination by 4 weeks. And it is completely contraindicated in post-renal transplant. And if you are preparing a child for transplant, would be probably like administered as early as 6 months of age for infants, for when you're preparing the child for transplant, or if the transplant has not occurred within 1 year, then you can actually repeat the dose of MMR. How about pneumococcal vaccine? So, like, it is very clear, children between 2 to 6 years who have already received minimum 3 doses of either your PCV7 or PCV13, then a single dose of PCV13 is recommended at least 8 weeks from the recent dose. And you have to also give your PPSV23 at least 8 weeks after your PCV13. So this is only when the child has received minimum 3 doses of your either PCV7 or PCV13. Next is the children who have between 2 to 6 years and previously unvaccinated, or children who have received less than 3 doses of your PCV7 or 13. In these children, you will have to give 2 doses of PCV13. Then you have to proceed with PPSV23 at least 8 weeks after the final dose of your PCV13. And booster dose of PPSV23 is recommended once in 5 years from the last dose. So, like, what is the advantage and disadvantage of giving what is PPSV23 and PCV13? Why is it important to give both the vaccines? So we'll have to understand little bit of immunogenicity in this. So if you look at this picture, when a child is given PPV23, it actually stimulates your B cell, plasma cells, and it creates your IgM antibodies. So this is actually a T cell independent B cell activation. So this is not going to be effective in children who are less than 2 years old, because there is no memory cells created. So when you give a vaccine, when you give your PPV23, it is not going to be effective if it is given for children who are less than 2 years, because there is lack of your memory cell protection. Whereas when you come to your PCV13, it stimulates your T cell as well as B cell, and thereby it creates a memory cell and plasma cell, and finally it is going to produce your IgG. So here your T cell and B cells are activated. So it is a T cell dependent B cell activation. So when you give this in a child who's less than 2 years old, your memory cells are very effective. So this is actually mandatory to know, because when you have a child less than 2 years, you are not supposed to recommend PPSV23, rather give a dose of PCV13 and then proceed with your PPSV23. So moving on to your varicella vaccine, it should be completely avoided in children receiving immunosuppressive drugs, including your corticosteroids. And once corticosteroids are discontinued, you have to wait minimum for 4 weeks. And it is completely contraindicated in post-kidney transplant children, and can be administered as early as 9 months for infants where you have a prospective where you have a schedule them for a prospective renal transplant. And the second dose can be administered as early as 3 months later. So moving on to influenza vaccine, the dose is again going to be should be given yearly, and the dose for 6 months to 3 years is 0.25, and more than 3 years it has to be 0.5. And children who are on dialysis and post-renal transplant should only receive the inactivated vaccine, and intranasal vaccine is contraindicated. Moving on to your meningococcal, your tetravalent conjugated vaccine is preferred, and booster every 5 years if the patient is on a deceased donor waiting list. So you will have to give the booster every 5 years if the child is for transplant and they are in a waiting list. Next is your HPV. HPV guidelines are not very clear in many centers, but what is routinely recommended is HPV 4 vaccine is recommended, and the age has to be between 11 to 12 years for boys and girls. For boys, you have to recommend a HPV 4, and for girls, it is for HPV 2 and 4, and it is not recommended in children who have a hypersensitivity for yeast. So this is a summary of vaccinations where you will have to think in a child with CKD. So basically, this is what has been said. The main vaccines to be covered for any renal patient is your hepatitis B pneumococcal vaccine. So for hepatitis B, the schedule is 0, 1, and 6 months, or you can also follow 0, 1, and 2 months using a doubling dose, that is 1 ml. If the child is less than 20 years, it is going to be 1 ml. If it is more than 20 years, you will have to give 2 ml, which is a strength of 40. And you will have to check again your titers, and it has to be more than 10 ml IU. Next is your pneumococcal vaccine. We have already covered that in individual vaccine. Varicella, most of the vaccines we have covered. All that we have to remember is your TT or TD killed vaccine. The booster has to be given every 5 years after renal transplant. So what are the travel vaccines for immunocompromised patients? So the recommended vaccines for travel to endemic areas, your Tdap, your IPV, your typhoid, your pneumococcal vaccine as per the schedule. Japanese B encephalitis vaccine, your meningococcal mostly recommended has to be the conjugate vaccine, your Hib vaccine, influenza, and oral cholera. And contraindicated vaccines for travelers or your OPV, intranasal influenza, your MMR, your varicella, your oral typhoid, and your yellow fever vaccine. So what is clinical efficacy? So like clinical efficacy is a proof of vaccine efficacy is merely the absence of disease. It means once you give the vaccine, that the disease for the vaccine for which you are giving, the disease has to be absent. So how do you check the vaccine efficacy? Basically, the formula for vaccine efficacy is attack rate in unvaccinated children minus your attack rate in vaccinated children upon your attack rate in unvaccinated. So these response cannot be done in individuals, and you need a large cohort studies. So in a cohort, it has been noted that children on peritoneal dialysis developed peritonitis caused by strep pneumoniae and H influenza despite the adequate serum antibody titers. So this shows that the serum antibody titers, which actually is very much protective in normal healthy children, might not be protective in children with immunosuppressed states. So these concentration might be very less in your peritoneal fluid as well. So this is a place where you'll have to give a repeated dosing of your vaccine. So what is the future direction? Continuous updating of the vaccination schedule is mandatory, and children on peritoneal dialysis and hemodialysis basically have disruption of the cutaneous barrier, pushing them to a lot of infections and peritonitis. And immunogenicity of some vaccine is impaired by dialysis, and vaccination might be necessary to induce protective serum antibody titers. And even if you have to cover the whole vaccine, it is even justified to delay renal transplant by 1 or 2 months just for the sake of revaccinating the child and creating a good antibody response. So in summary, children with CKD are often looked by multidisciplinary team. Your primary pediatrician, your nephrologist, urologist, everyone has a very key role. And all of us should have a standpoint that is like earliest opportunity to immunize all these children is mandatory, especially when you have the children who is going to receive immunosuppressive drugs or going to be on dialysis or likely to undergo renal renal transplantation. And we should try avoiding live vaccines in immunosuppressed children in whom prednisolone is more than 2 milligram per kg or more than 20 daily or alternate days for more than 2 weeks. And as already said, there are other various immunosuppressive drugs like cyclophosphamide, MMF, and everything has its own timeline for which live vaccines can be given. And we should understand inactivated vaccines can be given much safely in stable disease. And revaccination and booster is important if suboptimal response is detected. And hepatitis, the main vaccines and it is very mandatory to cover. Most of the vaccine has to be covered. At least a minimum of hepatitis B, pneumococcal vaccine, and influenza vaccines are particularly recommended in all immunocompromised children. And in renal transplant recipients, all vaccines are generally contraindicated for the first 3 to 6 months. It is because that is the time they have a very high immunosuppression state because of the high dose of immunosuppressive drugs. And household contacts and siblings should receive standard immunization, including your live vaccine, your MMR and varicella, and your oral polio and rotavirus vaccine. Thank you. So the best way to protect your kid is get them vaccinated on right time.
Very crisp and clear talk, ma'am. Indeed, and as rightly emphasized by you that, it's only many people forget that only live vaccines are contraindicated, and that is also very short duration of time. So one should always take that opportunity to immunize whenever you get chance to do that. So that's a really excellent talk, and I would like to congratulate both speakers because we are very punctual in matter of time. So both the speakers have finished their talk in the time given. So excellent. So I think we have time for question answer session, and Dr. Deepthi has already answered the questions asked to her as well as few other questions utilizing the time. And there is one question still unanswered in the chat boxes, that is vaccinations in patients with active glomerulonephritis. So would you like to attempt, ma'am?
What is that? I'm not able to hear. I was just looking.
Yes. It is vaccinations in the patients with acute glomerulonephritis.
Acute glomerulonephritis, a routine vaccination has to be followed because it is only a acute process. It is not like a chronic immunosuppressive state.
Right.
The routine vaccine as per standard protocol.
And I guess there is one more question, that is vaccinations. Should we prioritize vaccinations and to delay immunotherapies, or the treatment is priority? So kind of there is always a dilemma, like what to choose. I think that's what we want to ask.
What?
So vaccinations are the priority, or to delay the immunotherapy is the priority. But I think it is the case-to-case basis, maybe.
Yeah. It is always individualized because treatment of the disease is mandatory, but always say if it is a glomerular disease and when you have a remission period, that is the best time to get the children vaccinated rather than giving the vaccine during the relapse, because efficacy of the vaccine will be as such, it is only 70 or 80%, and during the remission relapse state, it would be less than 30%. So it is always better to get the vaccine during the relapse status.
True.
Immunosuppression cannot be avoided because it is basically the treatment to be offered for the disease.
Yeah, very true. I think rest all questions have been answered.
Deepthi has typed out her answer. Can you read out the question?
Yes. So somebody was asking your experience with gastrostomy tube after starting peritoneal dialysis. Is there a risk of infection? First of all, I would like to say that we have never put in a gastrostomy tube. So we are still hesitant like all of you. But people have been trying to convince us that it is very good. But yes, theoretically, the risk of peritonitis is much higher when you try to do it after the PD catheter insertion. And mostly all the guidelines which are saying or evidence which is gathering is whether we should do it before the PD catheter placement or during the PD catheter placement. So there's no question of after anyways. So, and even while comparing before and after, there's no much difference, they say, but they still suggest that you put it beforehand so that you're always at a safer thing. And as I kept on saying throughout my talk, there are beautiful guidelines. Before 2020, probably, we were nutrition and CKD was a very vague area. We only had the KDOKI guidelines, which had come in 2009. And they were the only go-to guidelines which we had. But now we have beautiful guidelines. And you can go to their websites, and all freely available pamphlets are there. You have the pamphlet specific for Indian scenarios, for our recipes, North Indian recipes, South Indian recipes. So, and even for the gastrostomy tube insertion with respect to PD, there's one complete page. So yeah, I would suggest you to read that. The second question was, what type of formula milk can be given to an infant in a CKD who is having hyperphosphatemia? So for hyperphosphatemia, breast milk or the express breast milk is best because it contains only half of what the whey-based protein formulas have, or the 1/3 of the casein-based formulas. However, if the child is already on formula milk, then whey-based is considered to be better. Some of the commercial names I've put there, like Similac and Aptamil, these are all considered to be low phosphate, not low phosphate, but at least on the lower end of the phosphate infant formulas. Phosphate is usually inherently a part of infant formulas because we know that calcium phosphate is supplemented. Even when a child is discharged from NICU, if he needs some calcium supplement, they are put on the calcium phosphate forms and not the calcium carbonate forms, which is given in CKD patients. Can you guide on persistent hyperkalemia in a 4-month-old child who has been on standard formula and CKD stage 4 and rest of the biochemistry is managed with drugs? So, as I mentioned, always look for the hidden potassium sources. Mostly it is the medications, RAS inhibitors, spironolactone, CNIs, amiloride, or any other things. Also see whether you're using any potassium additives. The hidden forms are there in all these processed foods. Processed foods have very high potassium content, and there are certain labels. You can look at the food label and identify if something like that is going on. If that is also not there, some non-dietary causes like constipation is also considered an important cause of non-dietary hyperkalemia. Rule that out after you have taken care of all the dietary and the non-dietary medication sources and nutritional supplements. If something, the best way is, I can't say that avoid this, avoid that. The best way is to look at the label of the food that the child is being offered. Look at the label, look at how much potassium content is there. Despite doing all that, if you feel potassium is uncontrolled, then we can go for the low renal specific formulas. Potassium binders can be added. And if nothing is working, then obviously dialysis has to be the last resort. And someone rightly mentioned that these renal specific formulas are not so easily available and very expensive. So how do we address that? Yes, it is a challenge, but then the localized customized formulas can be made with millets or with soya-based formulas, etc. But then it has to be a combined effort of a renal dietitian and a pediatric nephrologist. We need to figure out how much potassium can go in, how much this food contains, like how many grams of food I need to take. So it's a combined effort of both the renal dietitian and the nephrologist to sit together and make a customized plan for this child. And there's no single good recipe which I can suggest that you give this and potassium will be taken care of. It is much more harder than controlling the medications. And the final question was, would you suggest using of calcium lactate as a calcium supplement in a child who is having secondary hyperparathyroidism? If there is when you are not able to correct hypocalcemia, I believe, despite vitamin D and active vitamin D. So the most common formulation of calcium which is suggested in CKD is always calcium carbonate. It has good bioavailability and gives good calcium content. Calcium lactate, to my knowledge, is not a very preferred option for calcium supplementation in CKD. I would still say that you go ahead with calcium carbonate. The guidelines say that when there is hypocalcemia, you can go up to 2 times the SDI. Temporarily, if you're saying that there's still low calcium, high PTH, you're not able to get it, you can temporarily, means maybe for 1-2 months or 3 months, you can go above 2 SDI, but then make sure you come down. You would also be using calcitriol in maximum doses. And if nothing is working, then last resort would be, if the child is already on maintenance dialysis, probably you will also use a high dialysate calcium. I think those are the answers.
Yes.
Question, I think some again on immunization have come, ma'am.
Yes, ma'am.
I
So,
have my own question. Like, despite giving a low phosphorus formulas, you still have a very high phosphorus. Then how do you, is there any concept of adding phosphorus binders to the formulas?
No, ma'am, I have not heard of any phosphate binders, you're saying, right?
Yeah, phosphate binders
So the
to the
formulas
formula.
maybe,
Because I've heard from few people that despite having low phosphorus formulas, if still the phosphorus is very high, then they add the phosphorus some like binders to the formulas. Is it so?
I have no experience, ma'am. Dr. Jalpa, anything?
same here, ma'am.
Amri, is
I
there
have
around?
tried that. Yes.
Yeah, no, I think that's a very good question. And uh, we have tried that here, in some resistant cases. And definitely it is not the preferred option. It can be used in patients, say, if they are on continuous feeds, they are continuous G-tube feeds. So you don't get a window really. They are on feeds all throughout. And these we are talking about infants. So what you end up doing is that you end up adding the Renagel or so, or Sevelamer, to the formula itself. Because the formula is over like 20-hour period or 22-hour period. So you're not really getting any window where the patient is not getting any formula. So you end up adding to the formula.
So does it have any side effects?
No, I mean, I think we worry more about whether it's going to have an effect rather
Okay.
than the side effect, how much it's going to really work.
So is there any question on immunization?
Uh, yes, ma'am. So there are few questions for you. One is any contraindication to giving many vaccines at a time if the transplant is planned and it's not postponable. So how many maximum vaccines can you give? Or
Like what is advisable is you can give combined killed vaccines together, but it is not all that recommended. You can give combination of killed vaccines and one live vaccine, but in case if you're going to have a live vaccine, then you should have a window period of minimum 4 to 6 weeks for the next live vaccine. Combination of killed vaccine is fine.
right, ma'am. And one more question for you, ma'am, that if we do not have resources freely to get down the pneumococcal conjugate, is it okay to proceed with polysaccharide alone in the immunocompromised renal?
You don't have choice, at least something is better than nothing. You will have to give a polysaccharide vaccine, but the ideal thing is to get a conjugate vaccine. If it is not available, then you can't do anything about it.
Right, right. There were a few more questions on immunization, ma'am, but I think it has been already answered by Dr. Deepthi. So regarding whether to how much long before we give vaccination before starting rituximab for STNS, and I guess they are
I
all
think
covered.
rituximab, before starting rituximab,
Yeah,
I think there should be 8 weeks, at least 4 weeks, 4 to 8 weeks prior to planning for rituximab.
okay, okay, ma'am.
Post
And
rituximab, you will have to avoid your live vaccines for minimum of 6 months.
true, true. Yes, ma'am. I think almost all the questions have been answered, even for immunization. So that's it, I guess, ma'am, for the question answer. And I have one question for Dr. Deepthi, if especially regarding managing the diet in all those infantile CKD patients. So, do you have special dietitian related to kidney point of view or renal experienced in renal thing? Because I personally have issues regarding that, like to manage the kids, especially with the patient's load and everything. So, do you have dietitian available pertaining to or with special training in kidney regarding?
actually, no, it is the other way around that we are training the dietitians. We have one dietitian for the whole of the pediatrics department.
Yeah.
So we train them, and by the time they get trained, they move on.
Yeah.
So I mean, of the records, like we have a lot of technology-based apps which are available. So one app has been developed by AIMS Delhi also. It has been commercialized and is available at a certain price. So those kind of help you in your busy OPD because you can get a 24-hour recall. And yes, time is always needed. There's no shortcut to nutrition and CKD. Time has to be spent. You have to spend and get a proper history and find out what is going wrong, calories, proteins. But at least this technology-based apps would help you and document everything, and they immediately calculate and give you that this is the calcium, this is the, because it is difficult for us to do it manually. That how much calcium is the child taking, how much is the potassium is he taking. So it gets so laborious that we just leave it halfway. But if we have some app doing it for us, at least we know that, okay, this is suboptimal. Then you step up on the foods and you already have ready-made diet charts, you have ready-made recipes nowadays. So you at least can in a rough way, at least start with saying that do this, and maybe monitor it the next time. So I think technology-based apps are the best for a busy OPD.
Yeah, very true. So it's very important to take care of nutrition and immunization, especially not only tackling the potassium, creatinine, and BUN and stuff. So yeah.
Especially the cystinosis patients and all, they're like very, very malnourished.
True, true.
Amrish, do you have anything to say?
No, I think this has been a great session. I think you, both Dr. Kalaivani and Dr. Deepthi, you covered two very important topics. And nutrition is such a challenge, getting to grow these kids and especially getting them ready for a transplant because they have to be at least 10 kilos, they have to be bigger before we can get them transplanted. And if they are on dialysis, making them grow, I think that's the most challenging part, I would say, in management of CKD and end-stage renal disease. The formulas that we have here, we do have PM6040, which is a low potassium, low phosphorus formula. I think that's a Similac brand, and it does help. I mean, it does help to not give any extra, like binders or trying to, mix or, trying to come up with recipes of our own. So that does make our life a little bit easier here. And those are covered by insurances, so we are mostly okay. But still, even in spite of having a low potassium, low phosphorus formula, low osmolar load formula, still making these childs grow is a challenge. And I think nutrition is a very big aspect in in the management of these babies. So, no, thank you for both for sharing your experiences, and thank you, Dr. Jalpa, for handling the whole session so beautifully and finishing up on time. And I think we do have the polling session, so maybe we can go forward with the polling session.
Yeah, I have to personally congratulate Deepthi because like nutrition and CKD had always been a gray area. Like there was a lot of highlights after her talk. Thank you, Deepthi.
Thank you, ma'am. Thank you for the opportunity.
Thank you. So can we move on to the polling session, Amrish? Like I'll just see where the instructions. Amrish, you're able to see the projection slide?
No, I'm not. You
Yeah.
can go over it. That's okay. You can go over the instructions and then we can project the questions.
I think the instructions has to get projected.
I have it in my listing.
Is that?
I have it in my phone, so I can announce it, but I don't know how. So the polling session. So should I start with the instructions?
Yes, you can. I'm able to see the screen. Only thing is participants should be able to see.
Okay, okay.
It's okay. You can read the instructions. I think that should be good.
Okay,
So.
I'll read the instructions. So participants are requested to enter their proper email IDs and contact numbers because that is the only way of contact. And we have totally 6 polling sessions, and we have already done with one. And we have totally 10 questions, and it is mandatory to answer all the questions to proceed with submission. And the total duration for this polling session is going to be 6 minutes. Last time it was 5 minutes, but this time it's questions is sort of a little lengthier question, so we have kept it as 6 minutes. And we have 4 star questions in each session, and the star questions are taken into consideration only in case of tie. And the cumulative score of all 6 polling sessions will be taken into consideration for the final marks. And only trainees are allowed to participate in the polling session. So request all participants to log in on time using a bigger screen for ease of viewing, and a better view in iPad tabs use landscape mode. And why you can use the same link for the polling sessions. I think we'll move ahead. Can our IT team project the polling questions? I'll stop sharing. So the polling questions are projected, and so from now on, it is going to be 6 minutes. We are left with 2 more minutes. So we are done with the polling session. Jalpa, can we conclude the session? Thank you so very much for doing the wonderful moderation.
Thank you, ma'am. Thank you so much. Thank you, ma'am. Thank you, Dr. Amrish, and thank you, Dr. Deepthi. It was indeed a wonderful talk. Like, we are on time and with an excellent discussion. Like, the very important topic, I guess, for management of CKD, which needs attention. So, thank you. Thank you so much, Dr. Kalaivani, ma'am, for giving opportunity for this. So, thank you.
So
Thank
the
you.
next
Bye-bye.
will
Thank
be
you.
on April 19th. Bye-bye.
Bye.
Thank you, Deepthi. Thank you, Jalpa. Thank you, Amrish. Bye.
Bye.
Yep.
Good night.